We'll get going in a moment.
Morning.
Good morning.
Um, Christina just asked to let you know that she's taking a phone consult and will be joining a little bit late.
Thank you, Tony. All right, why don't we just get going then? Fit it in. Okay, so continuing on our trip through all the anti-arrhythmic agents, we're going to discuss Flecainide today. The brand name of Flecainide is Tambacor. You don't see that used very often because Flecainide has been a generic, has had a generic variety for many years now. Flecainide is a class 1C agent, and its use is predominantly for the treatment of SVT in our use, and it's mostly used for treatment of AVNRT or ORT, particularly helpful for WPW. It has direct effects on the His-Purkinje system, as well as on accessory pathways. Certain forms of right ventricular outflow tract PVCs will also respond to Flecainide, and so sometimes you'll see that it's used in that circumstance as well with good effect. However, very importantly, Flecainide is not used for ventricular arrhythmias in the setting of a myocardial ischemic event. And that's very important. And even though what I'm about to describe to you is not germane pretty much ever to pediatric cardiology, this comes up with some regularity because, of course, in the present era, parents will look online and read about the medicines that their children are prescribed. And so it's important that we all have a familiarity with the so-called cardiac arrhythmia suppression trial, or the so-called CAST trial. We've talked briefly about this in the past. So the CAST trial, or the cardiac arrhythmia suppression trial, was a double-blind randomized controlled study designed to test the hypothesis that suppression of PVCs with a class 1 antiarrhythmic agent following an MI would reduce mortality. So, I'll remind you that back in the early 1990s, late 80s, early 90s, there really was very little data on this. And as we have discussed, when people have a myocardial infarction, the reason that they die most commonly is that they have a serious ventricular arrhythmia that causes them to have sudden death. And this is one of the rationales for placement of ICDs in select patients who've had a heart attack. So in that era, 30, 40 years ago, when there was less known about it, doctors would routinely try different arrhythmia agents because there wasn't very much evidence for or against it. So in this study, there were 1,700 patients in 27 centers over what was an 8-year period. And the drugs that were used were Flecainide, which I don't even know if it's available anymore, Flecainide, and Miracicine. Also, I'm not sure it's available. And what was found was basically that they did successfully reduce the amount of PVCs. So on a typical Holter or a Zeo patch, you would see a substantial reduction in PVC burden. But importantly, there were more arrhythmia-related deaths in this group, and total mortality was significantly higher with both Flecainide and Flecainide at a follow-up of 10 months. And because of this, it is now considered, inappropriate and wrong to start a class 1C agent in somebody who has had a heart attack. So sometimes these agents get a bad rap because they were associated in the setting of a myocardial infarction with a higher incidence of sudden death or arrhythmia-related deaths. But, I always remind parents who bring this study up that this was a very different patient population than what we are typically seeing. Now, would I use this agent in somebody who, for example, had some kind of coronary artery surgery and was having PVCs, whether it's an anomalous coronary repair or maybe a transposition repair. Probably not, because there's usually enough other agents that it's not necessary to use this particular agent. But I would just caution that Flecainide in the setting of any disorder where you're worried about coronary perfusion, and I would put in that maybe even pulmonary atresia with intact septum, where they can often have coronary issues, probably not the optimal agent to use in those rare circumstances. And then more recently and excitingly, Flecainide is being used for the treatment of difficult to control CPVT, or catecholaminergic polymorphic ventricular tachycardia. So we all know that the mainstay of treatment for CPVT is beta blockade, typically with non-selective beta blockers such as propranolol or nadolol. But Flecainide is also an important adjunct in these patients. It inhibits the release of cardiac ryanodine receptor mediated calcium, and is therefore believed to medicate the underlying molecular cause of CPVT. And this has been demonstrated in mice models and also in humans. And so patients who have a difficult or a recalcitrant form of CPVT, it's not uncommon that we will place such a patient on Flecainide as an adjunct to the beta blocker, nadolol or propranolol. But I would say it would be fair to say it is rarely the first line therapy for that. But things change, and who knows, it might one day supplant beta blockers. I don't think so, but we'll see. How does it work? It blocks the sodium 1.5, the NAV sodium channel block channel in the heart, causing prolongation in the cardiac action potential. And the greatest effect of Flecainide is on the His-Purkinje system and ventricular myocardium. And importantly, it can cause a reduction in cardiac function. And so typically, it would be viewed as a negative inotrope. Now, sometimes one of the more common uses for this agent are tachycardias that cause tachycardia-induced cardiomyopathy. So a classic example would be somebody comes in ectopic atrial tachycardia and has ventricular dysfunction. And so then the question always arises, well, can you start Flecainide if it is a negative inotrope itself? I should add also that the negative inotropy doesn't manifest itself typically in people who have normal heart function. And the answer is that because the impact of achievement of sinus rhythm is so massive in someone who has a tachycardia-induced cardiomyopathy, any negative inotropy associated with the agent is far outweighed by the benefits of achieving sinus rhythm. And so we accept the fact that the Flecainide may have a minor negative inotropic effect in order to get the positive benefits of its efficacy against certain types of arrhythmia. Flecainide is one of these agents that has so-called use dependence, which means that it works better with faster heart rates. And so in some regards, some would say that it's better at stopping an arrhythmia than preventing one, although we would never use Flecainide as an acute agent, although some of you may be familiar in the adult world with the so-called pill in a pocket approach. So some patients who have rare episodes of intermittent atrial fibrillation will be given a very high dose of Flecainide to carry around, typically like 160 milligrams, and or maybe even more, and they're told that if they have an episode of AFib, they should take the medication to try to chemically cardiovert the arrhythmia. And it can be, in some select patients, it can be very effective. And I think some of you may have seen, I think Barry has a handful of patients who he has on this regimen. And it's a pretty good approach for people who have rare episodes and don't want to have an invasive procedure. In terms of metabolism and drug interactions, it has a very high bioavailability, and the plasma half-life is 20 hours in adults, but is substantially shorter in children. And it typically takes about 3 to 5 days to reach steady state. Flecainide is mostly renally excreted, but there is also some liver cytochrome P450 dependence for excretion, so one needs to be aware of both renal and liver function when you're starting or putting somebody on Flecainide, and potentially dose adjusted for those reasons. The next 2 points are very important, and you should sort of store them away in your memory banks, because someday, particularly Maya, it will be asked on your board somewhere. Amiodarone will raise Flecainide levels, so Those of you who have seen Barry and I start patients on Flecainide in addition to amiodarone will notice that the dosing that we typically use, as is the case with everyone, is very low. And the reason, of course, is because the amiodarone will raise the level, so one does not need as much Flecainide. Similarly, Flecainide will raise digoxin levels. And so one needs to lower the dose of digoxin one is using if you are using that in combination with Flecainide. So those are probably the two most important drug interactions. So again, Flecainide will raise digoxin levels, so you have to lower your dosing if you're putting someone on both agents, and amiodarone will raise Flecainide levels, which is why we typically use very little Flecainide as a dose when we're giving amiodarone, because a little bit goes a long way. Flecainide is dosed in milligrams per meter squared per day in small children, and typically we give 80 to 160 milligrams per meter squared per day divided Q8. Again, if somebody is on amiodarone, we would markedly reduce it, and many of you have seen that we often will start lower when we're on another anti-arrhythmic agent in combination with Flecainide, but if you're starting it sort of fresh on no other agents, typically 80 milligrams per meter squared per day is the standard dose. In adults, the starting dose is 50 milligrams BID. It comes as a 50 milligram tablet and can be given up to 150 milligrams BID. Many of you have already been to clinic with me and have heard me speak with families about Flecainide. Flecainide is a great drug, but it can be toxic. It can cause QRS prolongation. And so the most important reason that we get a 12-lead ECG each day when we're starting someone on Flecainide is to look at the QRS to hopefully not see QRS prolongation or PR interval lengthening. Both of those would be considered possible signs of toxicity of the agent. The toxicity can be enhanced by low potassium levels, so you want to make sure your electrolytes are normal. And if somebody has Flecainide toxicity, which is typically VT, we would typically treat with sodium chloride. Some people have talked about giving magnesium, calcium, epinephrine, and then interestingly, intralipids seems to be an effective therapy to rapidly lower Flecainide levels. It seems that it somehow binds to the intralipids. So, and I have, this is a very important problem of Flecainide toxicity because it has a narrow therapeutic index. And as many of you are aware, when Flecainide is dosed to children, it has to be made as a compound at the pharmacy. Unfortunately, it does not come commercially as a agent for babies or small children. So pharmacists have to make their own solution of it. And what can happen, and I've seen this unfortunately at least a handful of times, is that patients because the pill fragments settle to the bottom of the bottle, patients can be left receiving a very high dose of Flecainide when they're at the bottom of the bottle versus a new bottle. And so it's very, very important that Flecainide be dosed properly and that the bottle be shaken or mixed very aggressively prior to every single dose so that when the family is at the bottom of the bottle towards the end of the bottle's volume, that they're not inadvertently giving the patient too much Flecainide. And it's hard to do this because you can get bubbles when you're shaking it up. But the general rule of thumb, which I always share with families, is first of all, the bottle needs to be shaken all the time. Second of all, I make a point that this is a medicine that should not be given by just anybody. In other words, in a particular family, my general recommendation is that like two people, maybe the mother and the father or the mother and a grandparent, be the only ones who administer this medicine to the child. And the reason for that is because of the really dire consequences of giving too much of the medicine. The other thing about this medicine is that because of the narrow therapeutic index, I generally tell families that when in doubt, in other words, let's say it's not uncommon in babies that when you're giving a medication, sometimes a baby will spit out things very quickly afterwards. So now, and I pretty much tell them that unless it comes out like within the first 20 seconds of putting it in the child's mouth, one should assume that the child received the flecainide and just wait till the next dose. It is always better when dealing with flecainide to give too little rather than too much. Because of the narrow therapeutic index. So, really is a very, very important point, probably of all the medications that we send patients home on. This is one where really the family needs to be made very aware of how to properly dose this medication. And it's hard because in the hospital, as is the case with all medicines, the nurse is given a unit dose. So the pharmacist not only mixes it, but draws it up into a syringe. And so the nurse is not actually drawing it out of the bottle themselves. And so is not able to, sort of review that as, and demonstrate that in the hospital setting. So, it's a very, very important point. That's why I'm spending a lot of time on that. So that's what I have to say about Flecainide. Does anybody have any questions about that?
I do, Dr. Pass. So,
Sure.
if someone calls you like a patient that they accidentally gave double the dose, it's like each parent,
Mhm.
gave the dose. Actually
Yeah.
happened yesterday with one of Dr. Lowe's patients. But say like one parent gave the dose in the morning and the other parent didn't realize that the other parent gave it, so the kid got double dosed. What would you do? Would you just say to skip the evening medication, or would you want to have them come to the hospital to monitor them?
I guess part of it would really depend on what dose the patient is on.
Okay.
In other words, if you have somebody who's taking 120 milligrams per meter squared per day, I'd feel differently than if it was 80. But I'll be honest in saying that if it was a baby, I would probably think that the most prudent approach would be to bring the child in, at least to the emergency room or the clinic to get an ECG and confirm that the child is okay. I mean, there's no right answer to this, of course. It also depends when it happened. In other words, if it happened 6 hours ago and the child is fine, and the family knows how to take a heart rate, which thankfully most kids, parents of children with a serious enough arrhythmia to be on Flecainide, and it's normal, one could argue to just, I would certainly wait. I would not give the next dose, that's for sure, to let the level fall from whatever it is. But, that's the minimum. But probably being the nervous Nelly that I am, I would probably want to at least see the child.
Okay, thank you.
Yeah. Yeah. What did you do in that circumstance, Christina?
So this was like older child, like I think 5 or 6. They're on
Mhm.
50 milligrams BID, and Dr. Love just said to skip the evening dose.
Right,
Um,
right. Again, so if they're on 50 BID, the chances are they were getting tablets. And since the therapeutic range is pretty wide, I mean, 100 milligrams once a day, probably in someone who's not on other antiarrhythmic agents, is probably going to be okay because it is within the range of acceptable dosing. Also, the child got 50 milligrams because it's a tablet, whereas with solutions, it could be a little more or a little less. So it's always, you know, I try my best not to use flecainide in small children because of the issue with compounds and solutions that are made and concerns of the wrong dose. Uh, but I uh, I think there's no right answer. And the truth is that for certain arrhythmias, particularly for things like ectopic atrial tachycardia, flecainide is especially helpful, can often be life-saving. So I want to be clear, it's a great medication. It has many indications and it has saved the lives of many children, but one needs to use it properly. That's basically all I want to say. Any other questions about this? Okay. So we'll move on to one or two unknowns and we'll wrap it up. So this is a 14-year-old who was referred for an irregular heartbeat on physical examination. So my question to you is, what is this and what would you do about this? So why don't we ask Dr. Kitaki what she thinks?
Good morning, Dr. Pass. Um, okay, looking at the rhythm strip at the bottom, For the first two beats, it seems as if they're like inverted P waves,
Mm-hmm.
followed by QRS complexes and T waves. And so I would say this is some form of an ectopic rhythm. And then there's a pause, and then there's which appears to be P waves, which are uh, yeah, the first one appears to be upright, the second and the third one appears to be inverted like the one before, like the couple before. And they're all followed by QRS complexes, which is similar to the first two beats. And it seems this is how it keeps, the second set is similar to this one. And so it seems there's like a different morphology of the P waves. There's like uh, two different morphologies of the P wave.
Uh-huh.
Um, I think for
I agree with everything you've said.
for chaotic atrial rhythm, it's at least three, I thought.
Well, you have two here, so what could the two be? One, you already said that you think there's an ectopic atrial rhythm.
So
What's
yeah,
the other one, do you think?
it's probably sinus. So one
Mhm.
sinus and one ectopic. And is this some form of a wandering pacemaker?
Well, I mean, the term wandering atrial pacemaker is really, it's sort of an old-fashioned term. It's totally appropriate to use that term, although I wouldn't call this that. Usually when we say someone has a wandering atrial pacemaker, what that usually means is that when you're looking at a Holter or a Zio patch, typically in the middle of the night, a patient will be in sinus rhythm, and then maybe the sinus node will be a little bit slow, and you'll notice that the P wave morphology changes at a similar rate to the sinus rate. So in other words, you're in sinus rhythm, let's say in deep sleep of 52, and then at the same rate, you might see another P wave at a different morphology, but a similar rate. So it's sort of the term wandering connotes that you're going from sinus to some other focus that's very similar in heart rate to another focus. So that's what we think of with that. This rhythm, although not very fast, is, not a rate of 50, right? We're looking at a rate of like 110 or something like that. So we wouldn't call this a wandering atrial pacemaker. You would say, as you were saying, this is sinus rhythm with ectopic atrial rhythm as well, right? As you said, these inverted P waves do look like an ectopic atrial rhythm of some sort. So what would you, okay, so you're seeing this patient in the clinic and you're noticing that there seems to be at least one other focus that is firing at a rate faster than the sinus rate, causing the patient to go from sinus to an ectopic atrial rhythm, albeit, at least on this strip and on your exam, not especially fast. So how would you work this patient up? They've come, the pediatrician didn't have an EKG, but they heard this irregular heartbeat, and you've now made the diagnosis that they're having an ectopic atrial rhythm. So you're in clinic with the patient. What would your next steps be in evaluation of this patient?
So because the rate is still on the higher side, I would do an echo to find out what the cardiac function is.
Yeah, so I agree 100% with that decision because although, at this heart rate, right, we would not expect dysfunction to occur. However, we don't know, is this the best 12 seconds of the day of this patient? And are there multiple episodes where the heart rate is sitting in the 150s all day? Or is this the fastest and the worst of the day, in which case we would not be especially worried? So, we always think of the echo in this circumstance as almost like the hemoglobin A1C of tachycardia-induced cardiomyopathy, which is to say that if the function looks normal, then that should give you some confidence that you're not sitting in this rhythm at fast rates all the time. Okay, so you've done the echo, Katoki, and you've noticed that the function is normal. So what else would you do, or do you need to do anything else?
Yeah, and like for the reason you mentioned, I am going to put a Zio patch on this patient to see what the trend of the heart rate is, and to see how frequently the patient has these ectopic rhythms and what is the highest rate that they go and for how long do they stay in that rate, just to get a general sense of
Right.
their trend of their heart rates.
Right, because that would inform your decision-making regarding treating this, right? If, for example, this is the worst that the patient ever has, you'd think very differently than if you noticed that they were 3-hour episodes with heart rates of 160, right? And what would be the indications to treat this? So you have a patient, the patient is completely asymptomatic. He is telling you, this is news to me. I went just for a routine checkup and the pediatrician heard this. So what would be, as a cardiologist, what would make you want to treat this?
If the ZO patch shows that the patient is having a very high heart is having a higher or a high heart rate for a longer duration of the day for a longer period of time, if the echo shows that there's some amount of depressed function involved,
Mm-hmm.
then I would go ahead and treat this patient.
I agree with both of those statements. I'll add two more, though. So those are definitely true. I agree 100%. Those are indications to treat. The other would be if the patient is feeling it, right? If they're having palpitations from this arrhythmia. Now, we've already established in this case that the patient is not even aware it's happening, which is often the case. But the treatment of symptoms would be a good reason to potentially treat it. Although, again, this particular case, the child is not symptomatic. The other thing you want to look for on echo is dilation. Sometimes, in my experience, you can see dilation of the heart before you see dysfunction. So if you have, so a classic example would be somebody has an ejection fraction of 55%, so it's normal, albeit on the lower end of the normal range, and the Z-score of the LV is 2.6. That would be a reason to think about possibly treating it as well. That might be an early sign that a patient, has a problem. I have a patient I follow for many, many years who has an EAT that is very slow. And interestingly, when we tried to ablate it, we determined that it was right on top of the phrenic nerve was right on top of it. And so there was concern that any aggressive attempt at ablating this would cause diaphragm paralysis. But her heart rate in this rhythm was only about 85. It wasn't, 155. But it always has bothered me because her EF is normal. It's like 56%, but she's always about 2.1 Z-scores on her LV dimensions. But we've decided together that the risk of causing a diaphragm issue was not worth it. Now, there are techniques to potentially ablate it and not injure the diaphragm, but those are a little bit more advanced and carry slightly higher risk. And she has chosen to just stay on a low dose of beta blocker, which thankfully for her has been very good at controlling it. So yes, so symptoms or any form of dysfunction or dilation would probably be, or long periods that are not felt by the patient would probably be indications to either medically treat it or consider an ablation for this. And I think with that, we're going to stop for today. Thanks everybody for joining. I hope everyone has a wonderful day and see you in a short while at sign out. Thank you.